not be able to drop people for serious illness, which is something that, right now insurance companies can. It would end discrimination for pre-existing conditions, regardless of the public option, even if that doesn't pass, which it looks like it can now. Regardless of that, even if it doesn't, private insurers would not be able to deny people based on pre-existing condition. It's important to note both bills, the one in Congress and Senate, do include a public option. So those are both ways that if you have healthcare insurance right now, it'll affect you. You will not be forced to change your healthcare insurance provider. And if we do get a public option, that will definitely create competition for private insurers. So you will see a dramatic difference in premiums, either in if you choose to take the public option or because private insurers have to compete with that. And again, I want to note that the CBO has estimated a $30 billion reduction in deficit over the next 10 years, specifically for HR 3942.
I'm going to have to call time. I'm sorry. Dr. Hayne and then Mr. Field.
My only concern about the question is of us who work for people. I work for someone, and my insurance is paid for by that person. And if they have an option which is cheaper, they're going to change me to the cheaper option. I understand the reason for it, and I'm aware of that. So if I'm buying my own insurance, I do have the option to keep my insurance. But if, as a lot of us do, we work for someone, especially small businesses, we have to understand intuitively that a lot of the private insurance is going to switch over to public option insurance, for better or for worse, because it's cheaper. The economy's bad, people can't afford excesses, and we will switch more and more and more eventually to a public option. I'm not saying it's good or bad, but I think we have to go in eyes wide open that we really don't have absolute control to keep our old insurance. If we work for someone, that person's going to go with the cheaper option. So we have to be aware of that.
Thank you, Doctor. Mr. Field.
Not everyone will be able to. Neither employers nor individuals will be able to enroll in the public option. If you have a plan now, as written in all the plans, you are not eligible to enter the public option as written in law. There is an amendment to allow people who spend more than a certain percentage of their income. The last number I heard was 7%, who on premiums, who are currently insured in name to enroll in the public option. So your employer will not have the freedom to enroll you in the public option. So the short answer to it is that it will not affect you negatively. There will be changes in the rules about the way the insurance company can treat you. There will be changes in rescission rules. But in return, what the insurance industry will get is an individual mandate, which will dramatically, even with the so-called weak penalties in current law, will dramatically expand people's choice to coverage, and which should bend their cost curve down, which should keep you from major premium increases.
Okay, I'm going to go ahead and move on to the next question if we can. And this is an interesting one. Hospitals are, in fact, businesses focused on their bottom lines, essentially. The question is, why aren't companies, namely hospitals, being mandated in such legislation to provide affordable care to all?
Well, let me answer that.
I figured that was yours.
Why aren't hospitals being mandated to provide quality care at a lower cost? I guess that's the
essentially
summarized. Well, and frankly, hospitals are being paid less to be more qualified in the care that they give. That is happening in spite of any kind of a bill that goes through Congress. The reality is there are rules and there are regulations that are in place today that are continuing to require hospitals to produce better quality, a safer environment. At Florida Hospital Memorial, we have ongoing quality programs that are very tightly looking at specific measures, what we call core measures. They're national measures that are looked at for every hospital. And we are compared. We're out on the internet. The CMS, the Medicare agency, puts it out there on our behalf to compare all hospitals. How are we doing? So there are rules and requirements to do more, and the Medicare rates are being trimmed. It is a lower cost process, no matter what the bill does. So that's in place today.
Anyone else have thoughts on how Joe can provide more affordable care? Oh, you guys are too nice. I thought his answer was simple.
In theory, large groups of hospitals can provide cheaper care. Florida Hospital has group contracts, and they can negotiate better rates with pharmaceutical companies and, you know, gauze companies, whatever. So in theory, I guess if the bigger the hospitals get and they group together, the cheaper they can provide care.
Very good. Okay. I pay over $1,000 a month for insurance through our union. The provider is United Healthcare. They state they need to raise premiums over the course of the next year. However, the CEO and officers receive millions in bonuses. This is like the banks, right? How can this be controlled, presumably through legislation, or should it be? Mr. Field.
I think there are aspects of market power being abused here to increase profit, but I don't think that's the whole story. Underlying increases in premiums have been enormous increases in cost of care. We're unique in the world of not defining treatment boundaries and not defining in law standards of treatment. So cost of care does go up every year. Outcomes do not improve in a correlative manner with those costs, and it has very little to do with individual physicians. I think it has a lot to do with our payment system and the kinds of patients that come into the doctor's office, because we have a system where lapses in coverage are common, where we have pre-existing conditions, and a lot of patients don't receive care until we get to the point of rescue care. Like Dr. Hayne was saying, we have these heroic efforts to save people that could have been much more effectively treated with more quality of life at less cost if their diseases had been treated earlier. So there are, I think, a lot of factors that go into the cost problem.
To touch more on your comment than on the question, I think we just have to be careful, though, in terms of setting boundaries for care, because again, in England, women aren't getting certain chemotherapy medications for their breast cancer. They're not getting Herceptin. It's too expensive. It's a wonderful drug. It's absolutely proven to benefit 50% more than the standard chemotherapy. Not getting it. Is that right or wrong? I don't know. But certainly if we do have governments setting boundaries, not the doctor, but the government's going to be telling us what we can do. Sure, it's expensive, but my mother-in-law's had breast cancer, my sister's had breast cancer, my sister needed Herceptin. Some going to tell me she couldn't get it? 40-year-old woman? I wonder. We have to be careful about setting boundaries.
Benzo.
Joe touched on this a little earlier about healthcare versus health. Right now we have a sickness model, and that is that's part of what's driving the cost of our healthcare. We really need to focus on wellness, preventative medicine. Those are the things that will drive down the cost and the need for doctors and hospitals. But the point is, people won't get so sick and so early. As you know, we're getting heart attacks and